Thank you for joining the webinar. The idea of this meeting is to give you a quick overview of Parkinson's. Um, Now, each of the slides in themselves are a 1 hour talk, but we won't go into the depths of uh, um, each aspect of Parkinson's, and we'll try not to bury ourselves in a rabbit hole, but I'll try to give you a good overview of what's Parkinson's and what to expect from it. So why do people develop Parkinson's? It's because of neurodegeneration in the dopaminergic neurons, the neurons which produce dopamine, and in turn, people get dopamine deficiency, and that in turn gives you Parkinson's disease. And it is said by the time people develop Parkinson's disease, they usually would have lost about 50 to 60% of dopaminergic neurons. Now, why that happens? There are a number of reasons. This is a very busy picture, but the important things to consider here are aging. Aging is considered to be one of the biggest risk factors for Parkinson's disease. Then the second one is lifestyle, environmental factors. So epidemiological studies have shown that people who live in rural environment, who are exposed to pesticides, herbicides, people whose occupation was welding, people who drank water from a well, are at higher risk of developing Parkinson's disease. Now, it is like playing bingo. Now, if you are in that advanced age group and you've had those risk factors from the lifestyle point of view, and then if you have genetic factors that predispose you to develop Parkinson's disease, and if you click all these boxes one by one, and then finally an element of luck, then people develop Parkinson's. There are still unknown factors involved, but these are some of the major elements involved in people developing Parkinson's. And we know that the main abnormal protein is alpha-synuclein. Now, why is there neurodegeneration again? This is another way of looking at it. Now, start from the top here and all the way down here. This is how the abnormal protein progresses through the brain. It is believed, the picture that you're seeing is called Brock's hypothesis. Don't remember all the words, but it is believed the abnormal protein is first seen in the back of the brain. Now that explains when I say the abnormal protein, the alpha-synuclein is seen in the back of the brain. The first picture of the brain here, colored in red. And when it starts here, it affects your sleep centers and centers in the brain which control your bowel movement. And that explains why people with Parkinson's disease develop problems with sleep, problems with constipation, a number of years before they actually develop the physical symptoms of tremor, stiffness, or slowness. Now, what studies also show is once this abnormal protein starts in the back of the brain, it goes down the brain and then slowly starts spreading up the brain. And when there is enough abnormal protein that's gone onto the top of the brain, then people start having memory issues. And from start to here, people developing cognitive problems, it can take a number of years, and it differs from patient to patient. Not everyone with Parkinson's will develop cognitive problems. So it's all variable. Every person, every patient with Parkinson's is different. Now, we've already talked about the risk factors, rural environment, consuming well water, midlife obesity. These are again some of the risk factors. For once, Smokers and people who are addicted to caffeine, who consume lots of caffeine, are considered to be at risk of Parkinson's. But I'm not advocating anyone should start smoking now because they've developed Parkinson's disease. Now, I'm sure I see a lot of my patients are very well read. So they come and ask me, what about the gut brain axis and all? So I thought I would put a slide here. There is evidence that the abnormal protein, which I'm talking about, the alpha synuclein, first starts in your gut, in your bowels, and then through the nerves, it tracks its way up into the back of the brain, where your sleep centers are, where your centers which control your bowel movements are. So the abnormal protein first starts in the gut, bowel, and then tracks its way slowly up. Now, Parkinson's disease was first reported by an English physician called James Parkinson, and that's why the name Parkinson's disease. Um, the classical symptoms, what people would present with is unilateral tremor in one hand or one leg, or just one down one side. It could be right hand, right leg, or left hand, left leg. But most commonly, it is a very asymmetric tremor. And more often than not, it's just unilateral, just one hand tremor. Now, tremor plus people also start noticing stiffness in day-to-day activities, slowness in day-to-day activities, and some walking trouble. Now, the way the slowness manifests itself is, um, you know, hunched posture, slower strides, shorter strides when walking, slowness of movements, difficulty with repetitive activities like toothbrushing, chopping vegetables, cutting food, and some people resort to electric toothbrush, electric shavers because of that difficulty with repetitive movements. Some people, like I already mentioned, notice difficulty with walking, so they start shuffling and start taking shorter strides. And the typical posture is what you see in this picture. Now, we tend to concentrate a lot on physical symptoms, by which I mean motor symptoms. So, what people tend to see, like the shaking, the stiffness, slowness, these are all called as motor symptoms in medical language. But there are also other symptoms that we cannot see, like that's what in medical terms is called as non motor symptoms. So, that would be something on the right side of the slide, like problems with cognition, memory decline, anxiety, depression, sleep problems, fatigue, drooling of saliva, constipation, urinary problems, bowel problems, sleep issues. These are all non-motor symptoms. We won't be able to go over all of these, but I'll pick out a couple and I'll discuss in my talk today how to manage those. But most often than not, a lot of physicians and specialists and family physicians tend to concentrate on the motor symptoms, the physical symptoms, but it's equally important that we pay attention to the non-motor symptoms. Now, there are different types of Parkinson's, but to put it in simple terms, there is the one where there is a lot of tremor that would be classified as tremor dominant, and then there is one that is where there is a lot of stiffness, and that's classified as stiffness dominant Parkinson's. And then you get a mixture of the two, where you get a bit of tremor, a bit of stiffness, a bit of slowness. Now, Parkinson's, by and large, starts later in life, in sixth, seventh, eighth decades of life. But there are people who develop Parkinson's under 21 years of age. The youngest I've seen is someone 16 years of age, a young girl. Now, like I mentioned already, there is tremor dominant, stiffness dominant, and the treatment for all these would be slightly different. Now, if you see someone with Parkinson's, it doesn't start one fine day. Now, this red box is where a person with Parkinson's would get diagnosed, having seen a neurologist. But for a decade or two prior to that, studies show that they start developing prodromal symptoms. By prodromal, I mean before the actual Parkinson's physical symptoms start. So things like reduced sense of smell or total loss of sense of smell, constipation, acting out dreams, kicking, punching in the bed, like they're actually enacting what's going on in their dreams. Some people have mild anxiety, depression. And when this has been going on for some time, and on top of that, when they start developing physical symptoms, that's when family physicians refer to specialists, and the diagnosis of Parkinson's is made. Now, once the diagnosis of Parkinson's is made, most people tend to go on medications, levodopa or other forms of medications. Now, in the early stages, most people tend to get away with uh, maybe 3 doses of levodopa, one tablet 3 times a day. And for a prolonged period of time, which can last a number of years, and it differs from person to person, um, everything is hunky-dory. Everything is going smooth. One tablet 3 times a day controls the symptoms. People are happy that their symptoms are well controlled and there are no trouble. Everything's cruising along nice and smooth. And that's what I would call a honeymoon phase. And on average, about 5, 6 years down the line, people start noticing that the medication, which is mainly levodopa, is not lasting long enough. So you take a tablet at 8, 1, and 6, the 8 o'clock pill doesn't last all the way till 1 o'clock. It used to previously. Now it starts wearing off at 12 noon. And then between 12 and 1, you feel a bit stiffer, slower, shaky. And then you take a pill at 1 o'clock. The tablet takes time to kick in. And then you're feeling a bit stiffer, slower, shaky. And then it wears off before the next dose. So then people start having what's called as motor fluctuations. Now, when the tablet is working, it's called, and you're feeling great, that's what is called as on state. It's very important to remember these two words, on, off. So, off is when your medications have stopped working and you're feeling like the medication is totally out of my system, it's not doing anything for me. And on is when the medication is working at its best and you're feeling great. So when you start having these on, off fluctuations through the day, that's when you would say someone is in advanced stages of Parkinson's disease. Now, when someone is diagnosed with Parkinson's in my clinic, what I try to do is set realistic goals during the discussion. So there are symptoms which tend to respond better than others. So things like your stiffness, slowness tend to respond better to medications. Tremor is hit and miss. Some people respond to levodopa, some people not necessarily. Now, why that is the case? It's a complex thing, tremor. There is more than uh, one reason for that. But what studies show is tremor in some people is due to dopamine deficiency. In some others, there are other parts of the brain involved, other circuits of the brain involved, and that may not be because of dopamine deficiency. And that's why your tremor may not respond. So there is no way of telling whose tremor is going to respond and whose tremor is not going to respond. So as per this picture, I mean, this is not again 100%, but in general, what I would educate my patients in, things that fall in the midline of your body, like mood, memory, cognition, problems with speech, swallowing, bowel, bladder. These symptoms, which fall in the midline of the body, are less likely to respond to levodopa. Whereas things which fall away from the midline, your hand symptoms, stiffness, slowness, they tend to respond better. Now, you go through the initial phases of prodromal symptoms, and then you've had tremor, stiffness, slowness, and then you come to the stage where someone is diagnosed with Parkinson's disease. The next question is, when do you initiate treatment? Do you start the medications right away after you've been diagnosed as having Parkinson's disease? Do you wait? What is the ideal time? And what is the ideal treatment? There are so many tablets out there, medications out there. So what is the right time, and what is the ideal treatment that people should consider? Now, what I tell my patients in my clinic is, um, if the symptoms are affecting your quality of life, then you should consider treatment. If the symptoms are very mild, non-bothersome, and if you feel like you can control them with exercise, they are not coming in the way of your life, they are not holding you back in your day-to-day life, then you can consider holding off treatment. But the caveat here is, you don't want to hold off treatment for way too long, um, uh, with the hope that you might use levodopa or medications in the future. I'll tell you why you don't want to hold off treatment way too long in the slides down, further down the presentation. Um, so it's important to consider these things when someone is newly diagnosed with Parkinson's disease. So treatment, yes, you got to consider treatment, but what exactly are you treating? Are the symptoms bothersome? If they are not bothersome, you could wait and watch. Uh, um, what is the first best line of treatment? Uh, do you delay treatment as long as possible? So these are all some of the important questions to consider. If the symptoms are bothersome, then go ahead and start medications. Now, before you start the medications, one thing everyone with Parkinson's or even without Parkinson's should do is exercise. There is evidence that people who exercise in their 30s, 40s, 50s tend to have lesser risk of neurodegenerative conditions later in life. Now, even when you develop Parkinson's disease, if you exercise for about 30 minutes per day for 5 days in a week, uh, um, studies show that there is debatable evidence. I'm using the word debatable evidence that it might even slow down the progression of Parkinson's disease. Now, aerobic exercise, you can find out what kind of exercises you can do, and there are a number of resources for that. Parkinson's Society, BC, Parkinson's Canada. For people in on the island, there is Parkinson's wellness programs, and I'm sure there are similar programs elsewhere. So trying to keep yourself active is very important, and that has multiple benefits. It has improve benefits on your motor symptoms, physical symptoms like stiffness, slowness, they go down. It improves your cognition, it improves your mood. People who have mild anxiety, depression, because you're more out and about, active, that in itself elevates your mood. It also improves your gut health. So the more active you are, the more up and about you are, the more your bowels move, and that way you keep moving your bowels, and you have less risk of constipation. And because you are not as constipated, your tablets go through your bowels, and then they tend to work better. Now, exercise is also shown to improve your balance and your walking abilities. So dance therapy is good if you can access it. And there are a number of studies which show that exercise improves Parkinson's disease. Now, this is something hot off the press. I may have mentioned this to a lot of patients who come to my clinic. Now, what some a particular center in US is looking at is, why does exercise help? How exactly does it help? So they have coned down on this chemical called as irisin, which apparently is released from your muscles, leg muscles, arm muscles when you exercise. And when they injected this protein um, in mice with uh, Parkinson's, uh, the study showed that this chemical reduced the amount of abnormal protein in the brain. So there is some promise that this might help Parkinson's disease. So people are looking into it. It is still early days, very early days, but there is some promise from this end. But it has still a lot of hurdles to clear. Now, we've done the exercise. Now, before that, we've gone over the symptoms of Parkinson's. We've done the diagnosis. We've done the exercise bit, and now we come to medications. Now, there are a number of medications, as you can see. Which one do you pick? How do you make a choice which one is the right one for you? By and large, most people start off with levodopa. That is the best and the strongest medication out there. In the order of efficacy, I've put them from top to bottom. Levodopa is the strongest one. Then you have your dopamine agonists, ropinirole, pramipexole. Then you have your selegiline, rasagiline. Then you have entacapone, amantadine, and trihexyphenidyl. Now, ropinirole, pramipexole is not as strong as levodopa, but it is equally good. Levodopa came out in 1960s and still is the best medication out there. Now, each of these medications come with their own side effects. The slightly peculiar or specific side effects with the second group of medications, ropinirole, pramipexole, is the impulse control disorders. I'm sure you've heard of this. So things like abnormal behaviors like hypersexuality, gambling, addiction to internet, excessive spending, shopping. So those kind of abnormal behaviors can happen with ropinirole and pramipexole. That doesn't mean we should not prescribe and people should not take it. It's a very good medication taken in right dose and escalated slowly. It's a very good medication. Um, Entacapone makes your levodopa stay longer in the system. The last one on the list, trihexyphenidyl, I don't use it very often. I use it in people who have a lot of tremor and no cognitive problems. For most people with Parkinson's disease, I would go with levodopa, and if necessary, I would keep adding other medications as the condition progresses if necessary. Now, what do our Canadian guidelines say? What is the best medication out there when to start off as a first line? Our Canadian guidelines say go with levodopa. And what do other countries do? USA does the same. United Kingdom does the same. I trained in UK, and that's what we used to do there. We used to, start everyone, or rather, most people on levodopa. Now, there is some concern among people. I've heard from time to time who come to my clinic that levodopa is toxic, that it might cause more harm to the neurons. And that's why some of my patients raise concern that they don't want to start levodopa right away and they want to save it for the future. It may have been correct a few years ago, but studies more recently suggest that it's not a good idea to hold back on a medication which is as good as levodopa. You want to use it when you need it. Don't postpone it for future. So you keep postponing it for future, you leave it for future, and now your condition is slowly declining. So you don't want to do that. Again, there is concern. Some people develop dyskinetic movements if you start early. Well, there is no evidence as such. It all depends on how your Parkinson's is progressing. It is a combination of factors. So my advice to people is, don't postpone it for later. If you need it, if your symptoms are bothersome, take levodopa. Now, some patients in my clinic wonder why they are on immediate release, some why they're not on slow release. So there is always that question whether slow release works better than immediate release. Now, in patient groups, people also compare their medication regimes, and then I keep getting the questions, why not immediate release, why slow release, or vice versa. In early stages, there is no real difference. I would go with regular release. And what I've heard from my own group of patients here and elsewhere in the UK where I've worked, in the early stages, when you give someone slow release, it kicks in slowly, and then the peak, the best um, um, peak of action is not as good as immediate release levodopa. The peak is slightly lower than the immediate release levodopa, and then it slowly tails off. Whereas immediate release levodopa kicks in quicker, and then the peak effect is also good. So, in the early stages of Parkinson's disease, you might want to consider a regular release levodopa. As condition progresses, if you feel the levodopa is not lasting long enough, then you can consider a slow release. So what are some of the things you can monitor at home? So when you go to see your neurologist, things you want to have monitored at home, um, uh, this is what I tell my patients to keep an eye on. So um, do the tablets work as they are meant to? Does 8 o'clock last all the way till 1 o'clock? Does 1 o'clock last all the way till 6 o'clock in the evening? And what are your evenings like? Do the tablets kick in on time? If they kick in, how long is it taking? And does it wear off prematurely before the next dose? What is the difference between tremor, dyskinesia? Sometimes the tremor and dyskinetic movements can be difficult to differentiate. So there are some tricky things, but things you want to notice is how soon it kicks in, how long it lasts for, at the peak, do you get abnormal movements? In between the doses. Let's say you take a tablet at 8 o'clock and then the next one is at 12 o'clock. Come 10 o'clock, if you are having lots of involuntary movements, then it is more likely dyskinesia than tremor. And if you're not sure, it's always a good idea to get your family members to take a video of the movement, the abnormal movement you're concerned of, and take that video to your neurologist and show them. And picture is worth 1,000 words. So instead of trying to describe it, just show it to them that this is what I'm struggling with. So keep track of your symptoms is the idea of your slide. Make note of how your symptoms are through the day. Again, in the evening hours, can you get comfortable in bed? Can you roll over in bed at night from one side to another? What happens first thing in the morning when you wake up? Are you very stiff? Can you get out of bed? Can you go to toilet? Can you make a cup of coffee? Or you're so stiff that you can't move, you're struggling. So that's called as morning akinesia. So is that a problem? So you want to take notice of all these symptoms, write it down, and then prepare yourself for that next appointment with your neurologist. So what we're trying to do is, when you take a pill, we want it the levodopa levels to rise slowly, nicely, and last until the next time, and then the second one until the third dose. But as Parkinson's progresses, what happens is You take a tablet and you see this dotted line, nothing happens. It only starts working after a period of time. And that's called in medical terms as delayed kick-in. And then you're not due for another hour or half an hour, and then the levodopa wears off. It kicks in quickly, late, and also wears out of your system quickly, quicker than it's meant to be. And then you're left feeling stiffer, slower, shaky. And that's called as premature wear off. And when that's happening very frequently through the day, that's what is called as motor fluctuations in the world of neurology. And that's what is called as advanced stages of Parkinson's disease, what we call as on, off, on, off. So at this stage, in my inverted pyramid, you can pick off other medications and add to that regime. You can make the levodopa stay longer in your system by adding entacapone, or you can uh, increase the dosing frequency. Instead of 3 times a day, 8, 1, and 6, you can make 8, 12, 4, and 8, or you can consider slow release levodopa at that stage. So those are some of the tricks that you can consider. And when people start having motor fluctuations, this fluctuation on off, it's important to consider interaction with food. Are you taking a lot of protein in your diet? Is that what's causing the levodopa not to work so well? What can people do to help motor fluctuations? Check protein. If there is a lot of protein in your diet, try to postpone all your protein intake to the evening meal. Um, Treat constipation, take tablets on time as prescribed. Try not to move tablets in an erratic way. So have a fixed schedule. Uh, 10, 15 minutes or half an hour here and there is okay, but try not to have big swings. So morning, if one day it's 8 o'clock, don't make it 11 o'clock or 5 o'clock in the morning. Try to stick to a schedule. That way you have more predictable response with the medications. And then when you go to appointments, you are able to report to your neurologist that this is my schedule of tablets, and every time I take tablets, it's either kicking in on time or not, and it's wearing off before the next dose or not. So keep track of your symptoms and go prepared to the appointments. Now, when should you consider advanced therapies? We hear a lot, I'm sure you must hear a lot about deep brain stimulation surgery or duodopa or the new medication that's become available recently like Vyalev. Now, when should you initiate conversation about these advanced therapies with your neurologist? If you're taking 5 doses of levodopa, 5 or more through the day, then you should at least consider these advanced therapies. You should start a dialogue with your neurologist. You're taking more than 5 doses in a day of levodopa, and you're spending 2 hours or more in a day in an off stage. Off stage is when your levodopa is not working, you're feeling stiff, rigid, you're not having a good quality of time, good on time. And then if you have lots of involuntary movements, dyskinetic movements, more 1 hour or more in a day, then again, you should consider discussing with your neurologist about advanced therapies. So easy way of remembering is the rule of 5-2-1. 5 pills, more than 2 hours of off time during the day, and 1 hour or more of involuntary movements, then you should consider advanced therapies. So this is what a deep brain stimulation surgery kit looks like. There is electrodes that are placed deep inside your brain, and it's connected to a wire, and that tracks down the side of your neck and connects to a pacemaker that sits under your collarbone. So none of this can be seen outside. If you have plenty of hair on the head, then none of this can be seen. It's not going to stick out like antenna out of your head or anything. Um, it's been available since mid late 1990s. It's a fairly, I mean, I would say it's a good option for people with advanced Parkinson's disease. Uh, this is your duodopa kit. The tube, this is where your infusion syringe goes in, and this machine pumps medication directly into your tummy. Um, so basically, it's a gel form of levodopa. And the new medication that's recently become available is the Vialev. That's the phoslevodopa, phoscarbidopa. It's basically um, um, a needle which goes under your skin, and the needle is connected to a tube, and the tube is connected to this pump. It pumps the medication for 12 hours a day, and then you take it out at night, take your regular levodopa, and go to bed. Now, all these three advanced therapies are supposed to give you a fairly good on state, by which I mean you are feeling like your symptoms are well controlled, you are able to function well in your day-to-day life with minimal amounts of off time and troublesome dyskinetic movements. If you if someone should ever end up in hospital, it's very important they get it on time. By that I mean they get their medications on time. You're in hospital, you know, for a health reason, and that on top of it, if someone has Parkinson's and they're not getting their medications, that can cause further problems, like problems with swallowing, aspiration, then choking on food, saliva, pneumonias. So the best way to avoid complications is to make sure that if you're in hospital, make sure your nurse, your doctor is aware that you have Parkinson's and that you must get your medications on time. So, what is on time? You know, a 30 minutes window. If you're due at 8 o'clock in the morning, by 8:30 you should have had it. So half an hour grace period, but try to be as close to stick to as close to your schedule as possible. Now, um, here at Nanaimo, we have recently appointed a dedicated Parkinson's specialist, speech and language therapist. So, those of you who are on the island, please feel free to ask me next time if you want to see our SLP. We'll be glad to refer you. People from elsewhere on the island, inquire locally if you have access to speech and language therapists. People with Parkinson's can develop a variety of speech problems, softer voice, quieter voice. Some people develop that tip of the tongue phenomenon. They know the word, but they can't get it out. So these are all some of the problems that a speech therapist might be able to help. Other non-motor symptom is constipation, a very common problem. So things I would tell my patients is to keep well hydrated, plenty of fruit, fiber, vegetables, regular exercise, like we've discussed before, prunes, prune juice, again, keeps your bowels moving. Over the counter medications, speak to your pharmacist. Try medications like Metamucil. Ignore that center there. It's meant to be Senna. Then try Restorelax, psyllium husk, those kind of medications. But make sure you don't get constipated. That stops the levodopa from working very well. You want to get the maximum benefit of levodopa. So keep your bowels moving every day. Um, Anxiety, depression can start even before you develop physical symptoms, and that's tied to the abnormal chemical abnormalities in the brain. So try not to dismiss, try not to not acknowledge those symptoms. Acknowledge them. If you're anxious, then seek help for it. If you're feeling low in mood, acknowledge it and seek help. If you don't acknowledge it, the anxiety, the depression, kind of, if you keep bottling it up, it can overwhelm people and make your Parkinson's symptoms worse. Sometimes the anxiety is so bad that it overwhelms people and makes them feel like, their Parkinson's is 100 times worse. So it's good idea to nip it in the bud and get on top of anxiety. It also helps getting on top of anxiety when it comes to advanced therapies. If you are very anxious, if you have lots of mood problems, that might come in the way of you having advanced therapies. So the earlier it is identified and nipped in the bud, it is better for you. And some people run into this problem of postural dizziness. When you quickly rise up from chair or bed, you go dizzy, lightheaded. So things to do here are keeping well hydrated, increased salt intake if possible. Try to wear tight stockings. Some people can do that, some people don't like it. So don't take big portions of meals. Try to take smaller portions of meal more often. When you go to bed at night, elevate the head end of the bed. And when you're sat watching TV or just talking to your family members, try to elevate your feet with a stool. Avoid too much caffeine and tea that can make you pee out a lot of water and then dehydrate you. So some practical tips for addressing postural dizziness. So I've come to the end of my talk. Um, what are the take home messages? So start medications when symptoms are having an impact on quality of life. If your symptoms are mild, non-bothersome, that's okay. You can wait and watch. Um, when you have Parkinson's, it's very important to keep track of your symptoms. Remember, as neurologists, we only get to see you for half an hour, 1 hour, 15 minutes, or whatever that period of time, but you live with it. You know what your Parkinson's is like. When you come into clinic, you might be in perfect on state, and I might not get to see you in your off state. So it is important to take note of those symptoms and report it to your neurologist. um, Increasing levodopa is not always the answer for everything. Like I said, there are some symptoms which improve with levodopa, some symptoms which won't. So try to identify why exactly you want to increase the dose of levodopa. Discuss that with your neurologist. Um, Sometimes you might want to reduce the dose of levodopa. Some people get what's called as paradoxical freezing of walking. Their legs freeze with high doses of levodopa. It might be a good idea to pull back slightly on the dose of levodopa in such scenarios. Um, the on off keeps coming on very often in the world of Parkinson's disease. If your symptoms are coming on when the dose of levodopa has worn off, if you're feeling stiffer, slower towards the end of the dose, then that's an off symptom. If your symptoms like legs are freezing even when the levodopa is working, that is called as on state freezing. If the bothersome symptoms are coming on when the levodopa has worn off, then the answer is to increase the dose. Uh, Always, 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 please bring your medication up-to-date list to appointments. That way, you and your neurologist is working off the same up-to-date list of medications. There is no guesswork. Um, we specialists don't have access to family physician computer, so we don't exactly get to see what medications you're on. I can go on Pharmanet and kind of work out, but that may not be accurate of how many doses of levodopa you are taking. Sometimes there is different. So come prepared with questions. This is your time. The appointment with neurologist is your time to ask us questions. You've been tracking it for the last couple of months, 6 months, 12 months, whatever may be the time. So come prepared with your questions and fire them away in the appointment. One important thing is it's natural to talk to other people with Parkinson's disease in a Parkinson's group or friends or family, but try not to compare yourself, your medication regime or your Parkinson's to a friend's or a neighbor's or a family member's Parkinson's. Everyone charts their own course. Everyone is different. So someone is on slow release, someone is on immediate release, someone is on entacapone, someone is on something else. So everyone has different kind of Parkinson's. But when I say different kind of Parkinson's, I mean symptoms are different. So the treatment is always tailored to your symptoms, and it's not the same yardstick that's used for everyone. So everyone is different, not all have same progression. So try not to compare yourself. Thank you very much. Thank you for your attention.